Good evening. We've got a number of us cooperating to bring this to you tonight. We've got Judy Galton in the office here with us in Chatswood in the SNHN offices, and she's going to be our Zoom wizard. We've got Craig Parsons taking questions and chats he's also from the Sydney North Health Network, and any of you who've been to any of our meetings here before would know him well. Michelle Ferris from CCMB, Community Care Northern Beaches, and from the Mental Health Professionals Network in Melbourne, we have Amanda Oskiak, who's also helped bring this to you tonight. Okay, my name's Stephen Ginsburg, and I welcome you here tonight. For tonight, I think, in this strange Zoom world, I'm going to invite you all to be part of our tribe here, our tribe in the cloud. So welcome to a presentation that was to be given in March. I think we had about 50, 60 people signed in then to come to a meeting here, but due to social distancing, we cancelled it. And now, not that long afterwards, March, April, May, here we are, living well, dying better, compassionate communities. So we pay our respects to elders past, present, and emerging. On the left is a baby, obviously, and on the right is Uncle Bob Randall. Uncle Bob Randall died about 5 or 6 years ago, and the Medicare Local, as it then was, created a compassionate community around his care when he flew down from Alice Springs to receive medical care here, and then when he moved into the community and lived for a while after that and was able to finish his work and teachings. He had much to teach us about Aboriginal culture. So acknowledging that we meet today on Aboriginal land, always was and always will be, and acknowledging the elders of all of the communities in our area. First Nations cultures have survived on this continent for over 60,000 years. And prior to 1788, people were in better health than by most of today's indicators. And one of the ways that enabled families and communities, Aboriginal and Torres Strait Islander families and communities, to thrive in life and death were social structures based on self-care, from which the social prescription of a compassionate community has much to learn. I want to acknowledge here that when we presented at a meeting in DYRSL about 2 years ago that CCMB helped organise to launch the compassionate community concept in our area. Susan Moylan Coombs was there. She is a woman who was stolen generation, but then was adopted into the Nugget Coombs family. So she moves between traditional Aboriginal culture and our so-called modern world. And she drew to my attention that indeed compassionate communities were a new thing. But it wasn't really a new thing, because compassionate communities had existed in Aboriginal and Torres Strait Islander from 60, 80, 100,000 years ago. So Susan and I actually presented in Alice Springs together to a chronic disease conference and tried to interweave First Nations knowledges with the current compassionate community models to help create sustainable communities and improved social, physical, spiritual, and emotional well-being. Someone probably on the chat room is going to ask, what's social prescription? But maybe not, I don't know. We can certainly come back to that later. So I'd like to say that this is a strange way of having an interactive meeting. It's hard to have all of you. I think 121 people registered for this, and you're invisible and unable to shout me down as you would have done, I'm sure, if we'd all been in a space together. So as I venture into controversial areas of life and death, I hope I don't offend anyone's sensibilities, and I apologize if I do. So we're going to ramble around this huge yet simple issue of community connectedness, well-being and ill-being. And I'd like you to use the chat room as much as you like. What we'll try and do is, Judy says she's going to do screenshots of them all, and we may then compile all of the comments, perhaps not the ones that say, I can't hear anything or I can't see anything, but any contribution that you have for this evening's meeting, please put them on the chat room, or you can email them in later, because I'd like us to create perhaps a document that we can add to what I'm going to say. I'm going to speak probably for 50 minutes, an hour, all depend on how much I ramble and weave my way around. We'll have breaks, and I'll suggest breaks, and if people want to keep going, you know, Judy will let me know that. So I hope everyone's got their cup of tea or their dinner. It's one of the advantages, isn't it, of doing Zooms. And hello to you all. So I won't read this out to you. In fact, generally, I won't read what's on the screen. I might highlight something that we're talking about. And as you probably can see, I've got some notes here that I'm working from. Being 71, I've been compassionate to myself and saying it's all right, you're all right to have notes, you can't be expected to remember it all. So to add to this drive thing, I was watching a documentary on the ABC maybe a month or two ago, and it was about Nathan Buckley. You know, that'll be interesting to see how many of you know who Nathan Buckley is. I didn't have a clue, but he was for a long time a player for Collingwood and the coach. And I was at that time putting this talk together. And in his address to the playing group at the commencement of the 2018 pre-season meeting, Nathan Buckley placed a quote from a cyclist called Tuft, who maybe you know him. I'd never heard of him, but he's a champion cyclist. He put this quote on the big screen to encourage the team. And it said, "We come from tribal communities and we like to be connected. Most of us are still searching for a group of people that are going to do something special." And when I've been involved with compassionate communities, looking after someone or group, some of people, a family perhaps, I found that that has been very special and a very special experience for me. And there's a lot of research that shows that very often people who do what has been in the past called volunteer work, they benefit from it as much, obviously in a different way, to the recipient of their compassion. So here, bouncing into the screen, a piglet and Pooh. Piglet sidled up to Pooh from behind. "Pooh," he whispered. "Yes, Piglet." "Nothing," said Piglet, taking Pooh's hand. "I just wanted to be sure of you." And I think that is the essence of being connected. I hope everyone likes Lunig. I do, but I know he annoys some people, so apologies for those who he annoys. Care is the cure, it is slow, it is raw, it is pure, it is simple and bare, it is real, it is bold, it is there. Nothing is newer or older or wiser or truer. Care is the cure. So that speaks really to what Susan Moylan-Coombs was talking about. We live on a land where care is in the land that we live on. So you might say, when are we going to hear about compassionate communities, for goodness sake? When's he going to get on to them? Well, you may not hear anything about compassionate communities for quite a little while, because I think we all, well, I needed to know about care and what it really meant, and the difference and the connections to compassion. Two sources of my development of learning in this area was a book by, you can't see it because it'll be in reverse, but it's by someone called Professor Alan Kelleher, and I'll make comment about him a bit later, written, and it's called Compassionate Cities, and I think it was published in 2005. And the other organization is Groundswell, and we'll talk about them later. But in Alan Kelleher's book, where he promoted this model of compassionate communities and cities, the first chapter is drawing some of the differences between care and compassion and where they intersect. So care comes from the Old English and German grieving or lamenting, sickbed, and the Latin cure. It's an unequal concept of healing and helping, or it can be. In the medical world, it often is an unequal concept. It's the well helping the sick, the professional helping the lay, the knowledgeable helping the ignorant. But death cannot be cured. And for that aspect of compassionate communities, that aspect of compassionate communities that's to do with end of life, it's important to remember that death cannot be cured. Loneliness can be cured, mental health issues can be cured, sadness can be cured, or at least it can be acknowledged, but death cannot be cured. Death is a social more than a medical experience, but it has become, as we'll see, much more of a medical than a social experience. I forgot to do the little clicks, excuse me, but anyway, there they all are. Now, if anyone's interested, this presentation is going to become, I think, available to anyone to log on to the PHN site when it's launched, and we'll let everyone know that. I don't know whether it's going on the Mental Health Professional Network site as well in their library of webinars. Perhaps it will. So you don't have to write too much down. Compassion, empathy, altruism. Oh, all the lights have gone out. That's interesting. That's what happens in these offices. It only happens for a while, and it's rather nice. It's intimate lighting. Fortunately, there it comes. There we go. We're back. Compassion, empathy, altruism. There's 1,000 interpretations, probably many more, what these three words mean. Philosophers, sociologists, linguists. So I'm not going to read that one out to you. But compassion, as we'll see along the way, is really what we're talking about, more than curing. Now here come Pooh and Piglet again. Don't walk behind me, I may not lead. Don't walk in front of me, I may not follow. Just walk beside me and be my friend. This really is the essence of compassion. I was told many years ago that the Japanese word for therapy was one who waits with. So that sense of not doing anything for someone, but waiting with them, walking beside them and being their friend. My little stand keeps falling over. Anyway, there we go. Compassion, here it is. Pity, show mercy, sympathy or empathy. And it has two aspects. And that word, that root com, if you go online and see how many words begin with com, of course community does, and it's a sense of doing things with others. And it's a combination of attitude and action. Groundswell, who I'll introduce you to, the organization Groundswell I'll introduce you to in a minute, they see compassion as empathy and action. Represents partnerships, literally and sociologically, and in policy, because we want to bring this concept, this strong concept of compassionate communities, and embed it into primary healthcare policy, because it does have relevance for much of the work that we do in health. So why did I put this in? Well, I went to a wonderful talk once, and the person who was introducing it, he held out his hands and he asked the audience, look at your hands and tell me what you see. So I invite you to look at your hands and tell me what you see, except I can't hear you, but some of the answers will be interesting. So I look forward to seeing them later tonight on the chat. And some people say, I see lines, I see, they're very dry. And the longer it takes, people say, well, these are the hands that I do things with. And that then led this person into the answer that he wanted, is that these are the hands that care. They may be the hands that cure, and they may be the hands with a hug that is a compassionate action. Love thy neighbor, neighbor to neighbor, peer to peer. But also we need our ears, because compassion requires listening skills, and we need our eyes. I sometimes wonder if as I get older and older, I'm 71 already, what of my senses is going to go first, and will I be able to do my work? But at the moment, I think most of us here will have our hands, our ears, our eyes, and we are able to speak. Probably speaking is overrated. Certainly in the area of grief, a lot of listening and a lot of being with. So I'm now going to go into a little bit of health economics. I'm not a health economist, but being here in the PHN Medicare Local before, and still in the Division of General Practice, a little bit of health economics is important to know. So most people probably know this, the actual percentages are contested, but they're pretty much what's happening out there. I think we all know that. More and more people are going into hospital for palliative care. As I said, this compassionate communities movement originally was focused around palliative care. So these are important statistics, and they come from the federal organisation, Australian Institute of Health and Welfare. So these aren't just invented. It's a wonderful organisation. If you want to go on their website, you get a snapshot of Australia's health and ill health. And they don't usually make comments, but they made this comment in the latest one around palliative care. And it wasn't a favourable comment because it's unsustainable. 160,000 people a year die in Australia, and it's only 97 more. Very sad, but that number will be 97 or probably more this year with COVID. In general, hospital costs 3 times the cost of community palliative care. I don't know if any of you have heard of Dr. Ken Hillman. He's a professor of intensive care. He wrote a wonderful book called A Good Life to the End. And he's a great exponent of ensuring that people at end of life don't end up in his intensive care units. And he reflects on what wonderful and appropriate care could be given to people if in that last 3 months, instead of lingering in his intensive care unit, being with their life being maintained, and as he calls it, him torturing them, that they were at home with their families. His statistics say that very few of the people who he has in his intensive care unit who are aged and end of life last more than weeks or months. A&E admissions are increasing at an alarming rate. And then a few statistics on loneliness. People probably know these. And it's interesting, of course, that loneliness has become very much part of the daily discourse. I'll make reference to this later in this COVID era. So people are talking about loneliness and addressing it in a way that never happened before. It's extraordinary, isn't it, how fast we realize what our world is like. So, and another acknowledgement I'd like to make is that yesterday was International Nurses Day. And the nurses are underfunded and understaffed in the aged care facilities. This was just a screenshot of an article, and again, it'll be there on the webinar when we download it for everyone to see. You'll see Australia is the most institutionalized Western world, and yet we spend very little on long-term care of older people. I hope the chat rooms are filling up now with solutions and comments. Next week, I think, is National Palliative Care Week. So it was groundswell that 10 years ago, I was lucky to hear about them and become involved with their teachings. And the founders inspired me to explore this approach to death literacy. They have a wonderful website, so please go on it. At that time, 10 years ago, Home Hospice was very active and was a wonderful organization that really ran as a compassionate community. And then Life Circle evolved from that. Groundswell's an international leader in death literacy. Its vision is for communities to help us live, grieve and die in line with their values. And at the moment, Groundswell is very much focused on the end of life, but is exploring work into the workplace around these issues. They promote Dying to Know Day, which some of you may have been to and enjoyed. Last year, there were 200 events nationwide. In halls, workplaces, cafes, having the conversation. And that is some of the essence. I did say earlier not to talk too much, but maybe listen more, but listening to others as we have the conversation. Now, this is something that I might just leave on the screen for a moment. One of the great things of this webinar is that usually when I put this up on a screen, no one can read it. So I have to either read it to everyone, which is very tedious for everyone, or no one gets to see it. It started in life, I think, as a tea towel. Groundswell produced a limited run. I think they should do another run of them. It's a lovely linen tea towel, so that we could start the conversation around the dinner table. So I'll leave it with you for a moment. As you can see, they're keen to bring some humor into it, to normalize a conversation about death. We'll come to more of a discussion about death a little bit later. Groundswell are very active in their programs, both in the academic area of death literacy and working with the universities, but also in music, theatre and poetry. And a colleague of mine tells me that there's a group of out-of-work poets who've set up a program whereby they will write a poem and send it to a carer to cheer up their inbox and cheer up their day. So we might put the link to that into this presentation when it's available. I only heard about it in the last day or so. So maybe I'll move on. I do like the Margaret Mead quote, and I think this speaks to all of us. Never doubt that a small group of thoughtful, I hope thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So, I should ask Judy, have I had any comments about slowing down or speeding up, or, you know, leaving it? I'm insulted. I don't hear any comment from Judy. I'll continue.
No, it's there's one question there.
Okay, but now what we're going to do about the questions is I'm going to save them all up for the end, if you don't mind.
Perfect.
And then Judy will talk me through them, and I hope I can answer them. Also, Michelle and Craig are available. Craig is our mental health manager here at the PHN, and Michelle Ferris, as I said, works for CCMB as their dementia consultant. So feel free to direct questions at any of us. So I'm no statistician, but I like this that I read a little while ago. Care of the dying is a public health issue with 100% prevalence. Or put into poetry, Philip Larkin, most things may never happen, but this one will. He was talking about death. And the idea of compassionate communities are to return the care around death to the community. First Nations teach us that communities are the best place to have this conversation. When things are returned to the communities, they become much more sustainable than medical models can provide. Now, I'll come to these in a second, but there's some guiding principles. They came out of the era of inquisitive thought of the 1970s, which was the era that I started to be involved in healthcare and go to university and then medical school. And the WHO Healthy City program was developed 30 years ago to improve social and physical resources for the benefit of community. And they make an interesting comment on their website. It's a process, not an outcome. So much of what we're talking about is a process. Outcomes, I know, are an essential part of getting funding. You have to show that you've achieved an outcome. And I don't want to use that word organic too much, but this is more of an organic process. Public health, and I love public health. I'm a member of the Public Health Association and have been for a number of years now. And they look at things in quite a different way. Public health gets prevention, which is much of public health's work. And if we were all here, I'd get you to do a guessing game as to how much public health, what percentage of the budget public health receives. So I won't give you the answer yet. We'll come back to it later, but you might like to just put it on the chat room. What percentage of the health budget, federal health and state health budgets, are for preventive medicine? So public health addresses the social determinants of health and death literacy for compassionate communities. It's having the conversation. They're involved in social change, having the conversation. How did we manage to reduce smoking in this country? It was a public health initiative, and it was one where people had the conversation. Work around death and dying, mental health, suicide, loneliness. They all need to have conversations in the community. And part of the process, as we'll see a bit later, is community engagement and community development. More conversation. So I won't read this to you, but it was the Declaration of Alma Ata, and I can see you all Googling to find out where Alma Ata is. I won't tell you, you can go and look it up. This is a very brief summary. It was a meeting that defined the what direction primary healthcare should go in. And many people have said that not much has happened. There are these articles along the way published. How well are we doing with the Declaration of Alma Ata? And what I'm interested in, of course, for this talk is how it speaks to families in the community through their full participation at a cost that the community and country can afford to maintain at every stage of their development in the spirit of self-reliance, self-determination. The Ottawa Charter in '86 said much the same, reorienting healthcare services towards prevention of illness and promotion of health. I don't know whether Judy's had any percentages coming in on the chat room, but we'll leave it a bit longer. And you see that this was a international primary care conference, strengthening community action, building healthy public policy, creating a supportive environment. Not much talk about medical technology or medication. Whisked along my notes. There we go. So that's the first little bit of the talk. I'll take the first comment on the chat. Would you like a little break now? We've been going for half an hour and I think a stretch would be a good idea. I'll leave this up on the screen. These are the Sustainable Development Goals from the World Health Organization. And they are the cornerstone of public health. Most public health conferences has a little stand surrounded by pot plants and flags and whatever. And it's got this so that everyone's speaking about public health refers back to these Sustainable Development Goals. There are versions that are less and some that are more, but this will do us for tonight, I think. So I'm going to get up. You'll see a blank wall, just stretch for a moment, and I'll see you in just a couple of minutes. I'm back. Just went to have a little chat with Judy, who informs me that the chat room is going well and that you're getting some links put up on there, which is great. So it's almost like having you all here. Hello, everyone. I even see that Jess from Groundswell is here, so that's fantastic. Thank you, Jess, for all you've taught me. And Bryn's come in with a link to that poetry site. And you're all very well informed, because when I ask that question to some audiences, they say, oh, 20%? That's the percentage question. 20%, or some have even said 50%. They're hopeful. It's actually, I think we got 3 back in. One was 3, one was 5, and one was less than 10. The actual figure is 1.3% for prevention. And of course, here we're talking about things like prevention of loneliness and prevention of complicated grief and bereavement that have a huge, into the billions estimated. Grattan Institute loves doing estimates of how much these cost in lost productivity. It's a lovely word, isn't it? So the measures that we're talking about here are prevention measures and in public health. So this does have, I hope everyone can see this has relevance to compassionate communities and how we can help achieve some of these sustainable goals. It's been up on the screen, so you've all no doubt had a chance of looking at them. I've just circled a few in my notes here. In Australia, 2.9 million people live below the poverty line, and 730,000 children live in poverty. That's 17.5% of children under 15. Maybe we're not the lucky country. We've done very well with COVID, but we'll see. Some of these are very familiar, some less so. Climate action, so important, maybe one of the areas that impacts most on health. Sustainable cities and communities. The compassionate community concept has been rattling around international circles for a long time, and we're just starting to try and bring it more extensively to Australia. Life on land. Now, when Australia and all colonized countries were invaded, most of these sustainable development goals were compromised, sometimes completely destroyed. And that's why we can see such poor health outcomes in many Indigenous populations, whether it be Canada or New Zealand or Australia or anywhere else in the world, a lot of South America and America, of course. I'll talk a little bit later about deficit thinking, because of course there's a lot of strength in all of those communities. And the resilience to colonization is very strong. For our population here in northern Sydney, we have many vulnerable populations. And compassionate communities can address some of these. So, next slide. These are the social determinants of health, and probably teaching many of you to suck eggs, but I wanted to try and make this as comprehensive as possible, because we may use it to talk to groups of people who never heard of the social determinants of health. I'll leave it with you for a moment. I'll make note that healthcare services are down at about between 2 and 3 o'clock on the quadrant. This is accepted by all health economists, all health policy. And social and community networks, as you can see, compassionate communities fits very well into this view. Many health systems are waking up to the reality that many of their challenges are indeed socio-political. There are, of course, age, sex, and constitutional factors. But those are harder to change. However, we can change many of those other determinants. This is from an Aboriginal community, and I think it shows very nicely, very strongly, the importance of being rooted in the land, in the environment. Rooted in country, having a strong trunk, what some people call a strong backbone, isn't it? A strong trunk, and a culture sustained by the foliage, which is much the same as the previous, slightly more stylized social determinants. So I'll let you read that. New power. Citizens, not patients, citizens. They, on those websites, you go to them, you'll see a whole webinar on compassionate communities. The International Foundation for Integrated Care is one of the leading organizations in changing the way we look at healthcare. There's the Groundswell project. I'm sure Jess has already put that up for you. Public Health Palliative Care International. We held their conference here last October, 6th International Conference, Creating Compassionate Communities. If you go on their website, there's some wonderful videos of compassionate cities. We haven't come to compassionate cities yet, but just making note of that here. CCMB in our area has supported me in much of this work. Michelle Ferris works for them, and I thank and acknowledge them for the support they've given me. And there's a stolen from Wikipedia, but perfectly adequate definition of public health. So this book by Alan Kelleher, which you have to read back to front, does say public health and end-of-life care. So although it's similar to Love Your Neighbour, it has a very strong academic and practice base to it. I think everyone's seen how this pandemic, the COVID pandemic, has brought words such as public health into the daily discourse. And we've seen how powerful public health can be. It doesn't cost very much to say, stay at home. It wouldn't cost very much if the same message was got out. Be compassionate to your neighbour. And we have heard in this COVID time, as part of that public health work, loneliness and community, and indeed death, much more as words in the daily discourse. I hope I'm not being cynical when I say how quickly will we return to business as usual. There's the flyer for the Public Health International Conference, Compassionate Communities in Action, Reclaiming Aging, Dying and Grieving. And you'll see the themes speak to really what we're talking about tonight. It was a great conference. Alan Kelleher was there, retiring as the first president. I think president, anyway. He brought it together initially. There's the second Asia Pacific Conference. Integrated care is reaching out to all countries. I was able to present on compassionate communities to that conference and meet people from the UK, where compassionate communities is a very active part of their healthcare system. I think Kelly Arthurs is probably on this webinar, and Kelly, who works for Hammond Care, was given a scholarship by Hammond to go and see compassionate communities in action. And I think probably even met with Alan Kelleher while she was over there. So hi Kelly. And then I was hoping to present at the Toronto one, but sadly not this year anyway. That was the first North American conference on integrated care, and you'll see again, co-designing for health and well-being with individuals and communities. Everyone is talking about communities. A woman who was met in Melbourne, she's in charge of redesigning health for the Welsh health system, which is part of the NHS. And she said when they were short of a doctor's practice closed down, and they wondered how can we keep people engaged in their health. It was a little town, and someone said, what about the hairdressers? And it's very high up policy leader. She said it was fantastic. People were talking about health in a way they'd never talked before. Everyone has to go to the hairdresser in a little town. So we'll see that in a video a little bit. So integrative care, integration. We're integrating tonight because I looked at the list of people who had registered, and you come from a very, very wide range of care and compassion in our community and in our network. And I hope we can all join together and have the conversation and make the conversation and become more effective. Sorry about the little PowerPoint illustration. I love it when they say design ideas. This one popped up and it was quite relevant. making connection and having a conversation. PAL care, 80% believe it's important to talk about their care preferences. Only 25% have done so with their families, and only 6% with a doctor. Big program that Kelly was involved in tried to raise that number slightly. Doctors are too busy often to talk about such a complex issue. Broadening it out from end of life, from palliative care, 1.8 million people in Australia over 15 years old lacked social support. 1 in 4 experienced an episode of loneliness. And in 2014, the World Suicide Prevention Day joined to stress the need to acknowledge the crucial influence that social connectedness has on each individual. And as you know, or may have heard, the prediction, the modelling from Ian Hickey and others, Julia Gillard, Beyond Blue, is that the suicide incidents, particularly amongst younger people, is going to increase dramatically after this COVID era. Sometimes because of those social determinants of health and sustainable development goals, housing, employment, loneliness, social connectedness. This is a bit of a leap, but I hope you'll indulge me in it. I'll let you read it. Having the conversation, talking about suffering. It's the cornerstone of helping people in distress. And a compassionate, connected community can offer that. People with lived experience, we know, are very effective in our mental health services and communities. Connection and conversation. Now this is one of the busiest slides you're going to have to look at, and I couldn't break it down, but I'll leave it with you for a second. Moving through my pile of slides, that's good. So the health system's been very much in a top-down model for all of my time in the medical system. And indeed, my dad was a GP, and I could see from when I was a teenager and was becoming aware of the work he was doing and how the health system was set up, that it was very hierarchical. And we're comparing that with the grassroots, a groundswell, bottom-up approach. You'll see that this grid, as it were, comes from Indigenous thinking, Aboriginal and Torres Strait Islander thinking. Something I just want to draw to your attention is the approach and orientation. Our health system is very much a deficit thinking, weakness, what's wrong, not what's strong, but what's wrong. And then we try and solve it. We try and cure. And of course, we're very effective in many, many areas. We're a bit stumped by this COVID one, but it has shown many of the social issues that have been there before COVID. People have been suffering. People have been beset with fear and distress before COVID. COVID has exacerbated many of the problems. And many of them we haven't solved because they're not solvable unless one refers to the social determinants of health. So the grassroots approach is very much one for strength and capacity and improving competence within the community, upskilling, learning about death, learning about mental illness, learning about loneliness, naming it. Someone who works very much in the area of, well, it's her passion at La Trobe, and she in the area of strengths and assets, because compassionate communities are essentially an assets-based concept. And she says, when she goes into and tries to map a situation that she might go into, it could be someone dying alone, someone lonely. And she says, what's in the larder? What have we got that's strong, not wrong? And she loves to say, you know, you can go into, someone will say, oh, there's no food in the larder, there's no food in the fridge. And she says, she can go into these houses and she can put a very good meal together. She's speaking both literally and in metaphor. At last, we've got to compassionate communities. It's what you all came here tonight for. So you can see we've been leading up to high levels of community control and ownership. As I mentioned before, it was originally a vision for community to unite around their tribe at end of life. But now they can be imagined to be relevant across the whole range of life's milestones and challenges. It asks the question, are we people, citizens, or patients? This is a peer-to-peer compassionate support concept. Volunteers are almost a different concept. Volunteers are very important. Volunteers do wonderful work. And when you enlarge that role into their citizen role, as peers, neighbours, it enriches their role, raises their role to a different level of position in their community, one of equals. It's a shift in the culture of care and support. It's sustainable and affordable. We've seen those public health measures that have happened during COVID. Simple shifts in the culture of what we do, based on that principle. Nothing about us without us, nothing for us without us. The consumers, organizations have been telling us this for decades. Cradle to grave, wherever the social determinants of health define a new need. It's an interesting word, isn't it? Especially where loneliness and vulnerability exist. Perinatal, adolescence, frailty, homelessness, poverty, chronic disease, aging, dying, grief, bereavement. Disability. Disability is a huge area of distress, but also strength and resilience. So once again, to stress that pre-COVID, every day, every year was like a COVID experience that some of us have experienced, particularly those of us hearing what happens to people over 70. Fear, loneliness, despair, and facing death. Here's the Compassionate City Charter. And I hope you can now see why I've been leading up, as it were, to this during the talk. It's everyone's responsibility. I love this illustration. It was interesting, I tried to send this presentation to Judy, and Google kept on saying it had a virus in it. And I fiddled around and I tracked it down to this slide. And I thought, that's interesting. Some people would regard it as very radical, but actually it's very basic and speaks to everything that Susan shared with me and helped me realize. Here's a slightly different stylized view of it. That last Sunday of March was just going to be when we were going to be meeting up here to have this talk all together. There's someone signing the Charter for Compassion. And here's Compassionate Cities. We are working with the councillors in the Northern Beaches Council, to see if we can work with them towards the Northern Beaches Council becoming a compassionate city. A lot of the work's already started. A lot of the ideas are already there. The PHN's schools program, the program from the ABC about kindergarten children going into aged care facilities, the arts programs. So we hope just a little bit further along and we will be living in a compassionate city. City of Plymouth did it last October. And you'll see in there, I can't read some of the slides because I've got my picture in the way. So there are increasing demands on health and social care services as care becomes more complex and end-of-life needs grow, compounded by a national funding crisis in social care. Sound familiar? And then we're told, of course, we'll have to pay back this $320 billion. And where the cuts usually made: health, education, So let's watch for those austerity measures, and we'll need more and more for the community to care for itself. So she's the youngest ever cabinet member for health and adult social care. I've heard her talk. She's a very, very wonderful person. We fully support this approach and will work with our community to turn aspiration into action. This is compassionate community language, or those that work in this area, ComCom language. Now, time for a little video.
I had different people coming to see me, what I needed, and it gave me confidence that there is some good in this world.
If you become disconnected and feel lonely and isolated, it's very difficult to look after yourself as well.
When you get older, your whole life changes. Your children have grown up and gone, and I can't expect any person to keep coming here when they've got their own lives to be leading. I don't think anybody can explain what the loneliness is like. I was in a terrible state. I knew that if I didn't get somebody here to see me, that I would die.
So it's treating them with kindness and compassion and listening to their story and understanding where they are in their life and what needs to happen next to make that better. Right, how are you?
Very well.
Okay.
You were saying that you felt quite isolated.
Yes, I did. But coming to the club, we got into a little circle of friends and we all got to know each other, and it was nice seeing each other.
So we always give them, I always carry some brochures with me and I can give them the brochures. And when they get a hold of the health centre, the health connecting, then they're able to point them in the right direction.
We can just help people to get in touch with the support that's out there. There is so much support. And just to help people not feel sort of isolated, really.
We've got that 500 people who on average will talk to 20 people a year. That's 10,000 people put in touch with those resources.
They phoned up one day and they said they got this male that would come to see me, and that was the best thing ever happened. And I can't I can't tell people what a difference he's made coming.
For every £1 that's spent on this scheme, the NHS is saving £6. And the joy of this project is that you see the huge impact it can have on individuals, turning their lives around, being given back a sense of being part of a community again.
Here's one of Groundswell's fine postcards. There's more of them on their website. Groundswell works very strongly with many of their academic partners to develop this concept of death literacy into a death literacy index, so that we have some science, as it were, some sociological science to put with the concepts that are, I think everyone would probably agree, common sense. So just go back actually. Deaths tended to become invisible in our culture, mainly happens in hospital. And this death literacy concept, because we only ever hear about health literacy, and of course death literacy is part of health literacy, because dying well is part of what we're talking about. Dying with the support of a compassionate community. But we can also talk about mental health literacy, or loneliness literacy, or poverty literacy, or suicide literacy. Death, many words for it. Another use for the chat room, see if you can come up with any more that you heard, sometimes from another generation. Passing is one that we hear a lot, and I want to be clear that in no way is a conversation about dying meant to demean or diminish the challenges and complexities, the distress and difficulties that we encounter around death, or how different cultures experience and journey with death. So passing, and the use of the word passing in Aboriginal cultures has tens of thousands of years before the words they used around death were translated into this colonial word passing. Death and doctors. People dread death. I think one of the questions that have come in when we have a little break and then go to some of the questions speaks to that dread that we have. Back to the first noble truth. If we don't talk about the suffering that we're experiencing or expecting, it'll become worse. So we've become over-medicalized, what the Grattan or the AIHW called over-institutionalized, and indeed medicine is an institution. And it needs normalizing and giving back to the community, bringing people back to the community, talking about death in the community. I was very touched by a 96-year-old wonderful woman in one of the nursing homes. And I think she was quite ready to die. We'd spoken about it and she said, well, 96, it's a good innings. And she became very sick one evening. And I phoned the family and they came in. And the conversation was pretty much the same from all of them. When I said she could die tonight. She couldn't die tonight. Surely she couldn't die tonight. And my answer to that, usually, because I'm 71, is, well, I could die tonight. And it gave me an idea of just how far off we were from understanding death and how much we dread it. And through that dread, how little we can understand it. And let us not forget that the young die too. I'm just involved with a working group who tell me that the support for children born with congenital strengths, is often very poor, very limited, and the families struggle on. And we're hoping to bring the conversation into the public discourse more, and certainly into the compassionate community discourse, because they are facing death sometimes over many, many years. Likewise, younger people with cancer. Now, I think we're running out of time for me to go into what I was going to be the filler. If the whole system went down, you were going to hear me talk about what got me going in all of this. And it was reading in medical school these books by Ivan Illich. There's a lot of it on the web. If you're all here, I'd ask for a hands up of those of you who've heard of Ivan Illich. You can read the quotes. He was a radical thinker, and I'll just start with a little book, just a paragraph from a book review by a man called Richard Smith, and I'll allow him in that paragraph to explain how he came to hear Ivan Illich. This was the time that I was, of course, in medical school, and then the first years of walking the wards. So Richard Smith wrote in the British Medical Journal, "The closest I ever came to a religious experience was listening to Ivan Illich, a charismatic and passionate man surrounded by the fossils of the academic hierarchy in Edinburgh, and he argued that the major threat to health in the world is modern medicine. This was in 1974, and he convinced me, not least because I felt that what I saw on the wards of the Royal Infirmary of Edinburgh was more for the benefit of doctors than patients. I dropped out of medical school that day. 3 days later, I dropped back in again, unsure what else to do." And then he says, "Now I'm the editor of the British Medical Journal, which is ironic. Having deserted medicine, I've become a pillar of the British medical establishment." And he speaks so strongly about the prescience of Ivan Illich's writings. When you think that in 2040 in the US, $1 in every $3 will be spent on healthcare, you can see that Ivan Illich, who spoke about health as consumerism and another arm of capitalism, you can see why he was so prescient. And the last one's a lovely quote. He was always stirring, so nothing he said needed to be taken literally, but he was trying to get a conversation going. And that book in 1975, Tools for Conviviality, Living Together. In fact, I even heard that word convivial somewhere in the COVID conversation. Hadn't heard it in a long time since I'd read Ivan Illich. Richard Smith, the person who I quoted from, he was editor of the British Medical Journal, a bastion of evidence-based medicine, for 14 years, I think. He's now chair of the board of an organisation in the UK called Patients Know Best. Patients Know Best. So evidence base, he knows the evidence base. He helped create the Cochrane Review. And he knows that patients know best. The community knows best. People, citizens know best. Here's another quote from Ivan Illich. And I think what he's talking about is what Ken Hillman is talking about in his intensive care units these days. People who weren't able to have the conversation about how they wanted to end life. Did they want to end life in an intensive care ward, intubated, being maintained, or would they have done better to be at home with their loved ones, conscious and conscious of dying? We're just looking after an artist who's had 4 strokes and 2 falls, and the hospital said, well, it's either a nursing home, where I don't think an aged care facility, which I know and his family knew would not do him well, or to come home for however short a time to be with his paintings and with people close by. And a compassionate community has formed around him. So this is happening in our area. CCMB is building compassionate communities. They're building the framework, how to become a compassionate champion. And I think probably attached to the information you were sent out had some of the flyers for this. Is that correct, Judy? Oh, Judy's deserted me.
That is correct.
That's all right. Yes, it is correct. Yeah. So this series was starting just before COVID, and we had the first meeting at the French's Forest Bushland Cemetery, and people came and talked about death and dying. And the second one was last night as a webinar on advanced care, wishes and planning. It was excellent. We did a photo shoot at Manly Cemetery with a few of the compassionate champions for the Manly Daily, when the Manly Daily still was in print. And then I spoke to my brother actually he called me 2 days later and said, I heard a quote from you on in the Daily Mail. The Manly Daily is syndicated into most of the Western countries through Consolidated Press or News Corp. And the Daily Mail had 15,000 hits. 15 million hits with these sorts of comments that Laura Hedges had written up in the Daily Mail from that article in the Manly Daily. There's a great appetite for this conversation. So how do you start to create a compassionate community? This has been done all around the world. It's not just see how it happens. It has a structure to it, a frame around it, a loose and flexible frame. And in the video, you'll see some of this. BBC, the town that tackled loneliness. Neighborhood capacity. community development worker is a skilled and professional role. There's again, it's a university course, and I think we'll be seeing a lot more community development workers being trained to help facilitate. And facilitate, I think, is what you'll find they do. Not run or direct, but facilitate and help compassionately. This is a eco map that was in Julian Abel's talk when he was last over here. And you can see, probably too faintly, that in the middle is patient. I'd rather say citizen or person. The carer, the main carer, the network organizer. This system doesn't work often unless you have a network organizer. Someone who's good at spreadsheets with mobile numbers, maybe even a roster. This artist, there's just that sort of person. Good with the computer, great with spreadsheets. We're told that when he took it down to the hospital and showed his spreadsheet to the ACAT team, they said, "Oh, well, you're ready to receive him back home, aren't you?" He'd established, or they'd established the inner network and then the outer network. Julian Abel likes to talk about any of these can be filled with unusual carers. A cat sitting on the bed will keep someone who may be quite agitated calm while the cat is sitting on the bed. That cat is an important part of that inner network. Unfortunately for some, it has to be the television. Whatever it takes, the radio is good. Inanimate carers. Informal carers and formal carers. And you'll see down in the bottom left-hand corner, weak, vulnerable relationships, stressful or adverse relationships. The person who's looking at this has to see, well, they come in and they, unsettle everything. Beware. Practical support and emotional support. Simple. Someone once said, simple but elegant. And when it works well, as it often does, the outcomes, to use that word, are very pleasing to all. Everyone grows, even if someone dies. In the area of mental health or loneliness or disability, these are the kinds of eco maps that we need to create. There's Julian Abel, the Director of Compassionate Communities in the UK. I'll let you have a look at that. And you'll see that the largest cog in the wheel is the civic programme. Let's Hope, Northern Beaches Council, Hornsby Council, North Sydney Council. Then the next large cog are compassionate communities. The next one, generalist palliative care. That's primary care. The good nurses, the carers, the formal carers. And smallest of all, but essential, specialist palliative care. And as Julian liked to say, unless you've got that fan belt and all the cogs working and moving, it doesn't work as well. The fan belt holds it all together. I like to think that compassionate communities could be the fan belt. Won't spend too long on this, but in the chat room, you might like to fill some of the spaces. This is my policy hat that we love to do SWOT analyses. Old-fashioned, but very helpful. So in terms of the problems that face us, you can see that we've allowed decades of handing some of these issues over to the professionals who we need, but not just the professionals. The opportunities for social engagement, PHN, Council, CCMB, other organisations, the dementia-friendly communities, One Door. There are many organisations that we work with in the Sydney North Health Network that have the opportunity and do work with community, bring them together. Primary care, all the health professionals, also, of course, many strengths, many weaknesses, many threats to it working well. We're talking about these cogs, wheels, and fan belts. So feel free, you know, as we move into the last few minutes, to put onto the chat room where you see some of the strengths, weaknesses, opportunities, and threats. Create your own SWOT analysis of what we face. What we faced in a pre-COVID era and what we face in a post-COVID era. Because with austerity, we know inevitably, and with the distress that's rattled our society, the fear that we will need compassionate communities more than ever. So I'll leave this with you for a second. We're looking for sustainability and social change. Remember Margaret Mead in the Groundswell Manifesto. Possibility of creating a more compassionate society may sound far-fetched, but attitudes and values change over time, sometimes remarkably quickly. Maybe COVID will be a catalyst. If it isn't, so be it. But maybe that's the rapid change that she's talking about. As Councillor Kate Taylor from Plymouth said, let us turn aspiration into action. And unless someone like you cares a whole awful lot, nothing's going to get better. It's not. We can do it. Thank you. Thank you everyone at Mental Health Professionals Network, Sydney North and CCMB. And now you can throw your questions at me. I may not be able to answer them.
Okay, Stephen, the first one is, do more people die in hospital because we have an expectation that we will not die, so people keep presenting to hospital hoping for a miracle?
Very much so. Very much so. Absolutely spot on. We haven't had the conversation. Death is invisible. Why would we know any better? It's not a criticism. I think anyone can have these thoughts. They think they've come very much into focus around COVID because we've been faced with death. But Philip Larkin's quote, "It's going to happen. It's inevitable. Why not talk about it?" There's fear about talking about it, which is why we're encouraging a conversation. Remember the sign in the bus stop on the groundswell postcard or picture. Remember all of the little quips in the groundswell manifesto. I don't know if that answers the question, but I would just say, let's see if whoever that is wants to get involved and start talking and sharing that thought with others. Then the conversation has started. Thank you for starting the conversation. It's absolutely spot on. Of course, what we find is that less people die in hospital when they have a realization that that may not be the best place to die. And if they have helped create a compassionate community for themselves well before they die or near death. And it will help those that will grieve and be bereaved if the conversation is had well in advance. In compassionate cities, the conversation is had in kindergarten and schools. People grow up with it. There are wonderful children's books about death and dying. A very moving experience for me was visiting our grandchildren in Mexico City, and in one of the large galleries there was a huge canvas, and in it were some of the most shocking images of death and dying. And there was a little group, quite a large group, of Year 1 students with their teacher, and her English was very good. We asked her, doesn't it frighten them? She said, no, we focus on the things that they focus on, and we answer their questions. Have you ever known it to upset them? No. We answer their questions. Death is a normal part of life. Another question? I can't answer the question because there's no simple answer for it, but as you can see, I can talk under wet cement about death and dying and what's called a deathy.
Okay, how do you see this concept of compassionate communities being implemented in this very individualistic and material world?
I think we've just seen it, a little 2-month window of it, where letterbox drops were happening from the council and from the PHN, encouraging us to check in on a neighbour. Obviously, in this COVID era, you can't go past the door, but knock on the door, give them a phone call, drop a note into their letterbox. Can I bring you something? Particularly for older people who are more shut in, perhaps. Can we bring you a meal? Can we get a newspaper or a magazine for you? Would you like to chat on the phone tonight? It's happened. That's why I say maybe we'll go back to business as usual. But all of these compassionate cities have started small and then built it into the culture of their cities. And when you look at the Frome video, you'll see that it was over quite a short period of time, 3 to 5 years, that it became a compassionate town. Again, unfortunately, you're not here to answer the question. Maybe you've already said, but that doesn't answer my question. maybe we'll have when the COVID's over, we'll have a meeting where we can all sit down and workshop some of these ideas. Because that's how it happens. People sit down and they talk about it, and then what seems impossible becomes possible. All of those quotes on the manifesto, that last quote that I left you with. The impossible becomes the possible. The invisible becomes visible. Any more questions, Judy?
We've got about 6 more.
Okay, try and deal with them. How many have dropped out? Can you tell how many people have, packed up and gone home or stayed at home?
We only had about 10 drop out. We only had about 10 drop out.
Okay, congratulations for the rest of you hanging in there. I told you I'd probably get rambling and off topic, but maybe on topic. So apologies for that.
Next question. Would euthanasia be included in moving towards a compassionate community, giving elderly the right to die on their own terms, peacefully, pain-free and with dignity?
So this is a very big question. The simple answer is assistive dying, which I think is the word that's being used in legal circles to facilitate states to accept this concept in law. So assistive dying is certainly already in some of our states. So yes, it would definitely be part of compassionate care to facilitate the wishes of someone whose pain and suffering was such that it could not be relieved. Palliative care specialists, palliative care workers will say, if someone has really good palliative care and they have had the advantage of talking about their illness, if it's part of the culture and it's normalized, then they may feel differently about it. It's certainly not so for all. This is an evolving area, controversial, but I certainly am in favor if the conversation is had by all and had early, at the early stage of someone's illness, or better than that, before they even become ill. That assistive dying is certainly part of compassion.
I think this might have to be the last question. Will the medical profession change enough to take the whole person into consideration when they are in hospital, rather than just treating the symptoms without taking into account other conditions such as dementia?
I think they will. I think they will. I think it's happening already. I just spoke to a registrar today about this artist, and I was very, very impressed when she becomes a specialist and is leading the attitude under her leadership. I think she'll do it in a different way. I'm just looking through my papers for that quote from the Integrated Care Foundation, IFIC. Here it is. Here it is. Power is shifting as never before, so new power is addressing a vital issue for our time. How to make the voices and choices of all, not just a few, count for something. The citizen movement. Now that's a bastion of advanced medical thinking, and that's the way that thinking is going. We've got Ivan Illich's experience, the depersonalization, that he speaks so eloquently about it. Indeed, sometimes one can reflect and wonder how far we've got, like with Alma Ata or the Ottawa Charter. But I think the more we have the conversation, and this is a meeting of many professionals, and that we just have to lobby for it. and advocate for it and work hard to make it, our aspirations, come into fruition. I think that's going to be it, is it, Judy?
I think
Maybe
so.
I can answer, maybe what I'll do is, if you know who it is, I'll try and answer your question by email.
Perfect. Okay.
Thank you, everyone. Thank you, Judy, Craig, Michelle, and Amanda for helping organise this. Talk to you later. See you later.
Thanks,
Thank you.
Stephen. Thank you.
Bye-bye.